Welcome, everyone, and thank you for joining us tonight. It's 5:30 on the dot, so we'll go ahead and get started. We're really excited for tonight's topic that goes over the latest science updates in the world of Cambra and Carifree. Before we get started, I want to mention just a few things. If you have any questions tonight, please type them into the questions box on the right-hand side of your screen. We'll leave some time at the end to do some Q&A. If you find yourself wanting to learn more at the end of the session tonight, you are also welcome to contact us directly to schedule a meeting with you and your team. So with that out of the way, I'd like to introduce our presenter tonight, Dr. Kim Kutsch, also our CEO and founder of Carifree. Dr. Kutsch has been practicing 39 years now. Wow. Has published over 100 papers in journals. He acts as scientific advisor on dental caries for the Coy Center, and he reviews for multiple journals, including JADA, Compendium, and Inside Dentistry. He has quite an impressive resume, so I won't hold out on you any longer. So Dr. Kutsch, the stage is yours.
Hey, thank you so much, Kendall, and thank you everybody for being with us tonight. You always amaze me. This is one of the favorite, most popular webinars that we do every year, and it's always fun for me because I'm Mr. Science. So I do this all the time, reviewing science and look at what's coming out in dental caries, which is is my favorite topic. And so tonight I have pulled out some pretty interesting articles that I think will just help fill in and broaden your understanding, maybe answer a few questions that you have about certain materials and things. And so let's get started. I broke this into sections, and so hopefully these are logical for you. And the first section is Cambra. And I wanted to start with this article. This came out in the Journal of Dental Research in April of last year, and it looked at the oral health burden across 195 countries in the last 25 years. And they looked at both the global and then high socioeconomic demographics, medium and low. And if you look at the graph there, the top blue bars that's actually dental caries and deciduous teeth. The next bar down, which is navy blue, but it looks black here to me, is actually dental caries in permanent teeth, and below that is periodontal disease and then edentulousness. If you take a look at that, I mean, 65, 70% of oral disease across the board is dental caries. And so this is a global pandemic, and I think that the challenge for all of us as clinicians, and I know you all struggle with this disease as I do in your practices, is it has not changed. Oral health has not improved globally in the last 25 years. So we got a lot of work. I guess maybe that's job security, but we got a long way to go here. And we'll talk about kind of why that is, because I think there's some things that will kind of be enlightening here in a minute. This is a study that was done down at UCSF with a practice-based research network. This was my friends Peter Reckman and my mentor John Featherstone. They took 30 dentists. They examined, this was a 3-year study from 2011 to 2014. They looked at 900 patients. They used IC-DOS. They did 6 calibration sessions with the dentist to calibrate them as investigators, comparing sound tooth versus IC-DOS 1 and 2 non-cavitated type lesions. And then what they looked for was the CAPA inter-examiner reliability. And so the question they were looking at is, can we actually take Cambra, caries management by risk assessment, can we take this risk assessment model from the university level or the research level and actually apply it to private practice, and can we be reliable from practitioner to practitioner? And so this was just published in BMC Oral Health this month. And their average CAPA result was 0.84, which is very high. And so, basically demonstrates that you and I can be successfully trained to take risk assessment and actually apply it in general practice. So I think that's really good news, but I've been doing it. I can tell you it works because I've been doing it for 18 years in my own practice. So, and I know that many of you are doing that as well. This is a paper that was published in February of last year in Decisions in Dentistry, and shout out here to Brian Noby, one of the authors, Bruce Peltier, on this paper, and it published in Decisions in Dentistry. And it's kind of, and a shout out to them as well. I have to tell you, I'm a huge fan of the Caries Research Journal and JDR, JADA, Compendium. I mean, I know that you know that about me. But it kind of surprised as I looked at all the papers and literally a couple of hundred studies from this last year and narrowed it down to about 45 of them. I had a significant number from Decisions in Dentistry, and this journal is only 4 years old. It showed up on my desk one day in the mail, and it is peer-reviewed, and there's been some really good articles done there. So, kudos to them, because I pulled out a number of articles that you're going to see tonight just from that journal. So if you don't get it, it's maybe one that you would want to subscribe to. And I found this was really interesting. Implementing risk assessment can, pose challenges in your, in private practice. Anybody that's doing that realizes, there are some challenges associated with that. If you look at this chart, this was the thing that was most, I think, interesting to me, maybe alarming and at the same time. If you look at determinants of health, behavioral patterns account for 40% of disease, genetic predisposition about 30%, social circumstances 15%, environmental exposure 5%, healthcare is only 10%. So, when you go back to the global burden of oral health not changing in the last 25 years, well, we only play a 10% role in somebody's health. And so, we're up against a really strong headwind about their genetic predisposition and their behavioral patterns, their home care and their diet, their social circumstances. So if dental caries has feels like a challenge to you, it should be. I mean, we're up against a significant headwind here. So I thought this was a really interesting paper, and it really pointed out the fact that, there's a lot more going on in this disease, and we don't have as big an impact on it maybe as we'd like to think that we do. But certainly they propose, risk-based treatment planning is a very important part of our health care. This was a comprehensive approach article on early childhood caries, and the conclusion here that I want you to take away from it is that educating the parent or the caregiver for the kid is critical. Having them understand what the risk factors are and how that affects the disease is one of the most important things that we can do for parents, making sure they understand why their child has, early childhood caries. Again, this came out in Decisions in Dentistry just in December last month. And I thought it really points out we really need to make sure that we're helping explain this disease to our parents. The next article also came from Decisions in Dentistry. This one was from back in July. And I thought this was really interesting. It looked at caries prevention protocols for 3 to 6-year-olds. And we talk about it. I know we've talked about it in the Canberra group for years about, if you have a child or you have an expectant mother who's high risk for dental caries, treating her before the baby is born, trying to reduce her risk. It has a huge impact, and there'll be more studies that you'll see on that tonight yet, the relationship between the mother and the child and the disease. But here's actually a protocol, and they have it written in the protocol in the red circles here, moderate to extreme high-risk kids, recommend antimicrobial use for the parent. For caregivers, again, over-the-counter 0.05% fluoride rinse, like actively recommending treatment for the parent or caregiver while you're treating this 3 to 6-year-old as well. So I thought, for the first time, people are starting to actually include that in the protocols, and I think it's something, that's worthy of our consideration when you're dealing with a high caries risk child. Think about treating the parent or the primary caregiver at the same time. The next one was looking at caries prevention protocols again. This article also came out in Decisions in Dentistry in July, and really the conclusion was primary prevention is still the most cost-effective thing that we can do for these kids, and that is brushing every day with at least an 1,100 part per million fluoride toothpaste and flossing regularly. Those are the most effective protocols that we have in terms of prevention. And I know that's a challenge, for children under the age of 6 to flossing. So floss, and if you got parents that don't floss to begin with, convincing them to change their behavior to have their children floss is that's a challenge. And I'm doing a presentation at the Equilibration Society meeting in Chicago next month, and really looking at how to simplify the camber approach in private practice. And I tell you, we for years made it way too complicated and through way too many protocols and things that patients that, try to get them to change too many behaviors at one time. So that's really, just toothbrushing, and if you can get them to start thinking about flossing, those are the most important things that we could do for these kids. This next study I included because I think we're going to see more of this. It was pretty interesting, the results. This came out of Sweden, and it really looked at assigning benefits based on the prevalence of disease. And so they did this not by risk factor per individual, but they did it by geomapping. So they looked at the areas of the country where they had the greatest prevalence of dental caries, and they examined, included in this survey were 10,583, again, 3 to 6-year-old children. And then they followed them for a few years, and they distributed the money geographically based on where the highest levels of disease were. Interestingly enough, after 4 years, the total prevalence of dental caries at the dentin level was unchanged, but they at least got rid of some of the inequality and disparity, between the children based on their risk. And so I think we're starting to see certainly benefits being allocated by risk, but more on an individual level in this, in the U.S. And I think we're going to continue to see more of that. If you're low risk for periodontal disease, your insurance program is only going to allow you to have your teeth cleaned once a year. If you're high risk, you're going to be allowed the benefits. The money will be distributed to people that have the highest level of disease. And that's effective and appropriate. I just had never really considered allocating the resources geographically. And I don't know geographically in the United States. Now, I've never seen a survey. It tends to be everywhere. It's kind of ubiquitous, but so it's pretty much across all socioeconomic demographics in the U.S. as well. But I think that we're going to see more of this allocation of benefits based on risk as we go, continue down the road here. And I thought this was kind of an interesting study. The next study I thought was quite interesting as well, and this was done in Northern Ireland. It was a randomized controlled trial on 1,096 2 to 3-year-old children. They looked at in 22 different dental private practices in Northern Ireland. In the test group, the kids got fluoride varnish, a toothbrush, and fluoride toothpaste, and advice on prevention. In the control group, the kids only got advice only, and parents got advice only. The primary outcome that they looked at was conversion of caries-free children to caries active. Secondarily, they did analysis just on DMFS. The intervention group's mean cost was 212 pounds more than the control group. So while we think of prevention, primary prevention, fluoride treatments, fluoride toothpaste as being a lot more cost effective, in this study it actually cost more than in the control group. However, when you looked at the level of carious surfaces, it was cost effective. So just looking at children as a whole, do they have dental caries or not, it costs more to put them in the prevention group, but when you got down to actual surfaces, caries surfaces, it was actually more cost effective. But it does raise a concern that, we need to be careful of, just spending money on prevention doesn't necessarily reduce the overall cost or the burden of the disease. So I think this brings out an important point for us all to be aware of. The next category that I have then is, I've been teaching the usual suspects for, let me back up here for just a second. I've been teaching the usual suspects, saliva, diet, bacteria, and then genetics, trying to get people to associate and identify just patterns of this disease so that you can, kind of have a very quick feel for where you're headed. And so, the first topic then we want to look at tonight is saliva and what kind of studies have been done on saliva in recent past. This article came in, this was a case report, and it came in Dentistry Today back in February of last year. I thought it was interesting from the standpoint that they looked at anticholinergic drugs that were being used for urinary incontinence and overreactive bladder. And I hadn't really thought about the fact that you might get xerostomia from somebody who's being treated for, incontinence. Never really registered, I think, on my radar. So I think that's something for us to consider. Gee, there's another risk factor, certainly as it relates to medication-induced xerostomia. The challenge that I have is this is a photograph from the article, and to be honest with our science, I mean, if we talk about what does a patient who has xerostomia look like, they have dry tissue and they have no saliva. And so this is pretty serious decay, and if you ask me just by looking at the photograph what caused this looks more like a dietary issue to me than it does saliva. And I mean, I see saliva bubbling between the teeth. So this is not, I mean, you'd have to measure the salivary, production, but when you see that much saliva, I don't immediately think xerostomia or hyposalivation. Certainly, I didn't see a risk assessment done on this patient, but if you ask me, I would tell you this is not a xerostomia case. However, I didn't see the entire patient and have their entire medical history and what have you, but it does raise the point that these anticholinergic drugs certainly could play a risk factor. So somebody who is being treated for incontinence, if they're taking those medications, that's something for us all to be aware of and keep that in mind as a risk factor. In this next study, they took 74 school-aged children. They examined the saliva flow rate, the saliva pH, buffering capacity, and then they looked at carbonic anhydrase 6. Carbonic anhydrase 6 is a protective enzyme in the mouth. It's a defensive enzyme, much like beta-defensin 1 that we've done a lot of research on. And so in this study, they looked at both the concentration of carbonic anhydrase and also the activity level. And what the conclusion was in this study was that the flow rate, the pH, the buffering capacity, and the carbonic anhydrase concentration was higher in the caries-free children, but the carbonic anhydrase activity was higher in the caries-active kids. So children with a higher activity of carbonic anhydrase in the saliva are more likely to be children that are developing dental caries. And this study came out in July 2017 in the Caries Research Journal. Carbonic anhydrase may or may not be something that you've heard mentioned, but I think you're going to see more of that too, because I see a lot more of that going on in the research being kicked around as a potential biomarker, or certainly something we need to look at in terms of patients that have high risk for dental caries. That really was about some of the best studies that I saw on saliva that I thought were significant in the last year. The next topic is diet. And again, if you look at just a broad pattern of what is somebody who has primarily a dietary risk factor look like, they're typically either eating too much sugar or they're consuming the sugar too frequently during the day, snacking, etc., sipping on sugar-sweetened beverages. And typically, a person that has a dietary issue, they have lesions spread throughout the mouth. They're everywhere. There is no pattern geographically for the lesions. They're just everywhere. So if we start to look at diet, this paper was published in July in the Journal of Dental Research. This examined the global burden of sugar-related dental diseases in 168 countries and then the corresponding healthcare costs. And the conclusion was basically 26.3% of global disease burden is caused by consumption of free sugars. So certainly our diet, when we go back to behaviors and how that relates to the burden of health, free sugars, are certainly an issue. They're and added to just about everything that you pull up, any kind of food you find in the center of the grocery store, in the center aisles, and I don't know how we're going to change that, but that's certainly, it's a huge issue, and I think that's just with dental diseases, and certainly these free sugars play a huge role in other systemic diseases in the body as well. And one of those is diabetes, and so this is looking at an association between diabetes mellitus sugar-sweetened beverages and tooth loss in adults. They looked at, this data came from 18 different states. They had included 95,897 adults in the study, 14,043 had diabetes, and 81,854 were otherwise healthy. They did regression analysis on this and basically found that, among adults with diabetes, consuming 2 or more sugar-sweetened beverages was associated with having 6 or more teeth extracted. Now, the one conclusion also they said, but that really just that there wasn't enough evidence just between a direct relationship between the sugar or the amount of sugar and the amount of tooth loss didn't really explain it. And then I think we have to look at things like, certainly we know that diabetes is a cofactor or can be a cofactor in periodontal disease, and they didn't really look at in this association the cause of the tooth loss. Could it have been from periodontal disease in addition to dental caries? So certainly we know there's an association, and drinking 2 sugar-sweetened beverages with all of that added free sugar every day is not either good for your teeth or is it good for your body. And that was published in July in JADA of this last year. The next study that I included on diet I thought was quite interesting because I have almond milk in my refrigerator at home, and I know many of you do as well. And this just came out in the December Caries Research Journal, and they looked at 6 different almond milks, a soy milk, and then 1 bovine milk. They compared biofilm growth, strep mutans in vitro. They looked at then the pH of the milk, the buffering capacity. And the conclusion was that the almond milk that was non-sucrose sweetened, so unsweetened almond milk, was the least cariogenic for patients that are lactose intolerant. So you have a recommendation if you've got a lactose intolerant patient. It's like, yeah, if you're looking between soy and almond milk is best, but make sure that it's not sweetened with sucrose. So that pretty much concludes what I've included for you on the diet. When we move on to then looking at bacteria, again, there no new smoking gun in terms of bacteria in any of the studies that I saw last year, and actually not really any newly identified cariogenic organisms, but really just kind of a broadening of our appreciation of how the biofilm behaves and what it does in this disease. In this first study, this really looked at salivary proteins. You're going to hear a lot more about in research, and then also comparing the bacteria in early childhood caries risk development. And the conclusion of this, looking at a lot of studies, was that strep mutans and Sobrinus are considered etiologic agents in early childhood caries, whereas Prevotella, Lactobacillus, and Candida are responsible for the development and the progression of the disease. This was published in the International Journal of Oral Science this last year, and I think in November. And again, I think pretty much just a continuation of what we already understand. I would just caution you on the strep mutans as an etiologic agent in dental caries, particularly in children. 40% of kids in this country, and most of the studies, have 0 strep mutans at all. So, and they have severe early childhood caries. So, looking at that as that's the smoking gun, I think that's a bad model, and I've said that before, and I'll continue to say that again. It certainly brings it into question. So, looking again though at salivary markers and the bacteria as biomarkers for this disease. This was a study that was done in Canada, in Saskatchewan, and the question was: is there a difference between the biofilms in our First Nations children versus, just, school children from Winnipeg? And so they took 30 First Nations children who were less than 6 years old. They all had severe early childhood caries, and they compared their oral bacteria to 20 caries-free children from Winnipeg. They did PCR and 16 RNA analysis. They looked at 28 different species. The results were the Veillonella and Porphyromonas were 4 and 9 times higher in the severe early childhood caries group, whereas strep gordonii and strep sanguinis, which we, those have kind of been the gold standard for healthy bacteria in the mouth, were 5 and 2 times higher in the caries-free group. So extremely high levels of strep mutans were detected in the severe early childhood caries group, and the microbiome associated with severe caries in Canadian First Nations children is significantly different from the caries-free Canadian children. This came out in JDR in November. Again, I think this just continues to add to our knowledge base. Certainly we expect that you would have a significant difference between caries, severe early childhood caries individuals and caries-free individuals. But again, the Vianella and the Porphyromonas were the ones that were most high, or there was the most significant difference between the two groups with respect to the severe early childhood caries. In the next study, I thought this one was quite interesting as well. This came out in PLOS ONE in October of 2017, and they looked at interdental. The question was interdental plaque. So if we took healthy, and these were healthy adults, 25 caries-free adults aged 20 to 35, they did PCR for total strep species, strep mutans, lactobacillus, total Enterococcus species, and then Enterococcus faecalis, as well as Candida albicans, and then total bacteria. And then they looked at the total, interdental plaque. And the results from this are pretty interesting. You can't really see it. Okay, so we're back live. Moving on to a new topic, genetics, which has been, and now that I have audio control, I don't have control of the mouse. Oh, we're back. Okay, so we're back. Next up is genetics. And you saw in that earlier paper from Brian Novi mentioning that genetics plays about a 30% role in the determinants of health. The researchers that I talked to on this topic with dental caries say it's somewhere between 30 and maybe as high as 60. So genetics certainly this is kind of a new field. It's really, I saw the first studies published in about 2010, 2011, looking at genetic determination for dental caries, and there's been just an explosion of research on that. We've probably got close to 45 genes now that have been identified that are positively associated with dental caries risk. This is one that I thought was interesting because for the first time they looked at both the development of the level of calcium and phosphorus in saliva and determined that that was actually affected by genetic determination as well. In the study, they took 276 12-year-olds. They did 15 variants of 9 genes, and the results were Amylex, which has long been associated with enamel development, and we know is associated with dental caries. And then 2 more genes were also found to be significantly associated with the calcium level in saliva. So not only, so here's another risk factor, calcium and phosphate levels in saliva, which can also be a genetic risk factor as well. In this study, they looked at, again, at human beta defensin 1, which I mentioned earlier, that's a defensive proteolytic enzyme found in the saliva. It's been studied extensively throughout a lot of European and Middle East countries on adults primarily, but we know that there's a huge genetic, and actually it's been studied here in the United States, a huge genetic correlation between your polymorphism, one of the 3 different polymorphisms for this gene. And this study then looked at 678 Brazilian children. They did a dental exam and they collected saliva, and they found that the human beta defensin 1 level was significantly higher in the caries-free children. And again, that's consistent with what we know on adults. But this came out in Caries research back in May of 2017. So just, again, reinforcing that those salivary, protective enzymes, and this looked at the microRNA level, it's involved in caries risk. This next paper was a systematic review, again, looking at genetics and its influence in dental caries. They looked at 30 papers that had subjects anywhere from 30 to 13,000 individuals involved. They looked at single nucleotide polymorphisms on 30 different genes, and at the end of the study, 3 genes, AMLX again, AQP5, and ESRB, have the most promising evidence based on multiple replication and data providing that these genes play a role in dental caries. So we're continuing to expand that knowledge base, and we know that, certainly there's a huge genetic component in dental caries. The next study was looked at from 3 separate countries, Italy, Mexico, and Saudi Arabia. They looked at 13 to 15-year-old children. They tested them for their sweet taste threshold and their sweet taste preference. They used ICDOS and DMFT as their measurements, and they found a weak yet positive correlation was found between taste perception and taste preference versus the DMFS and manifest caries in all 3 of the countries. This came in the Caries Research Journal in July. Again, there's been several other genes associated with taste, sweet taste and bitterness that have been demonstrated previously, but this is the first time I've seen for the sweet taste threshold. But again, we know that sweet taste then affects, typically their selection of foods and their diet, which then plays a role in dental caries. So that's genetically determined as well. And this one I included on genetics. I thought this was really interesting. They looked at MMP2, and we know that we've looked at a number of matrix metalloproteinases. These are enzymes that are found in dentin that are responsible for the breakdown of proteins in dentin, which tend to break down the bond, our resin bond, and which lead to composite failure. And so this is the first study that actually determined that restoration failure can be genetically predisposed, and particularly it was related, there was an association with MMP2. This was done in the UK. They took data from the dental registry and the DNA repository. They looked at 4,856 patients. They looked at 6,266 amalgams and 2,010 composites. They evaluated them at 1, 2, and 5 years, and then an additional 807 patients were evaluated at the end of 10 years. The interesting thing at this is the failure rates of amalgam and composite were similar, but by 5 years, the composites were outperforming the amalgams. So I thought, well, that's very interesting, and it appeared to be that smoking and drinking alcohol will increase the chance of restoration failure as well. But certainly MMP is associated with restoration failure. So I thought that was very interesting, something I don't think we really considered or taken into consideration, as the restoration failure of your composite restoration, is there a genetic component to that? So that's the first time I've seen that, and I wanted to share that with you. Next, we just look at studies that talk about risk factors. This study came out of southern Brazil. It was a cross-sectional study of 538 mother and children pairs. The children were 2 to 4 years old. They looked at both DMFT in the mother and DMFT in the kids. The children with the highest caries rate were from mothers with the low socioeconomic background or had the highest caries rates. So again, this reinforces we know that maternal risk factors are a strong risk factor for childhood caries, and this was published in the Brazilian Dental Journal in May of 2017. So again, we talked about earlier, treating the parent, talking to mom, making sure they understand the risk factors. This next study then was is looking at birth weight, low birth weight, maternal smoking, and then breastfeeding. And so the baseline was at age 1. It was a 4-year longitudinal study. Like I said, it was 1,102 Scottish children. And what they found was that birth weight, breastfeeding, and maternal smoking were not associated with DMFS at baseline, but birth weight and maternal smoking were significantly associated with DMF at age 4. This came out in JDR in February. However, there was no association, the good news here, no association between breastfeeding and dental caries at age 4. But certainly we need to, certainly this just reinforces what we know about low birth weight and cigarette smoking and risk for dental caries. The next was a longitudinal study in the relationship between dental caries and obesity in late childhood. So they took children that were age 7 to 9, and then they re-examined them as adolescents at age 12 to 16. This study was done in Northwest England. In the study, there were 5,470 patients, and overall, the dental caries rate and obesity rates were high in the entire population. However, what they determined was by age 12 to 16, body mass index was not correlated to dental caries. So it may be a cofactor. There may be a again, cofactors for this, in these between these two diseases, but there was no significant correlation between body mass index and dental caries by that age. And so I've seen studies in the past that indicated body mass index was related to caries risk. We reported a study last year to you that came out of India that low body mass index, when they were lower than normal, actually they had increased caries risk as well. And it may have some influence on saliva flow rate has been implicated in that as well. And this came out in the Public Health Journal in October. So not necessarily related in adolescents, certainly in this study. The next paper examined, this came in Decisions in Dentistry, and examined the relationship or children with special needs and that increasing their risk for dental caries. Therapy for these kids, we all have these kids in our practice. It can be challenging, and what we really need to do is be very aggressive with our preventive measures, such as frequent recalls and regular fluoride treatment. Certainly, I think even here's a population that maybe silver diamine fluoride is appropriate for as well. So we need to be very aggressive in our prevention for these kids. The next study is a systematic review. There were 2 independent reviewers. They started with 79 studies. They narrowed it down to 9 that were included in the study, and they looked at caries risk in patients that had bariatric surgery and had never really taken this into consideration. And me as well as you have a number of patients in my practice who've had bariatric surgery. Certainly it changes their diet and their eating patterns and abilities. And within the limitations of the study, patients who have undergone bariatric surgery may have greater risk for dental caries. Now, whether or not this was a cofactor, they just found this correlation, and it's could be well related to the dietary changes that occur after they've had the bariatric surgery as well. So something, again, not something I'd read before in the research literature, not something I'd really thought about, but for your patients who have had bariatric surgery, that's a risk, could well be a risk factor for dental caries, and something for you to kind of consider and maybe counsel them on. Next article is a review article on Shogun syndrome. Again, somebody that has xerostomia, Shogun syndrome, what do they look like? They have there's no saliva. Like if you look at this patient and compare it to the photograph of the patient that had the incontinence, there is no saliva bubbling here. This tissue is, by and large dry. And so you've got somebody that has a dry mouth. Certainly Shogun syndrome is very challenging because it increases their risk for dental caries. And one of the things that you see even in Shogun's patients is a lot of times you'll find lesions even in the mandibular incisors. Now I've talked about this before in terms of genetic risk with the Lysol-2 gene, but when you see a patient that has decay on their mandibular incisors, they have new lesions on mandibular incisors, you have an extreme problem. You have an extreme risk. You need to figure out what's going on, because those are the last men standing. If a patient has 6 teeth left, you and I know which 6 teeth those are. These teeth are the most protected in the mouth. They are bathed with 2 liters of saliva from those submandibular glands every day. And so it's like, these are the teeth that are most protected. And when you just see decay there, that should, the alarm, the red light should be flashing. I mean, you've got a huge issue going on there. So typically, in Shogun syndrome, you're going to see decay again throughout the mouth. but you're going to see it probably, and if you do see it in mandibular incisors, you have a real serious issue going on. The next article was a review, and a shout out here to Dr. Doug Thompson and his Wellness Dental Network. I got to tell you, I know a number of you are members of his Wellness Dental Network. This was published in Compendium in October, and again, a shout out to AOSH, the American Academy of Oral Systemic Health, and this was just a review article in Compendium looking at oral health as it relates to systemic health and in the clinical care of an aging population. So certainly that's, you know, we've all made this connection, and I think AOSH is doing a great, and Doug are doing a great job of, I think, educating the profession on the oral systemic connection. While we're on that topic, this is not dental caries, but this is, however, periodontal disease. But I thought I'd include this. This was in the Journal of Dental Research in June, and again, looking at periodontal disease and its relationship and overlap with coronary arterial disease. And again, not only can oral health affect, you know, systemic diseases. Systemic diseases can have an influence on, like diabetes, can have an influence on periodontal disease as well. So we know that that works both ways, but I think that there's certainly genetic susceptibility contributing to both periodontal disease and cardiovascular disease. So that was a great article on that. Next up is a review article examining SubOptimal oral health, and this was just published this month in the British Dental Journal, and looking at suboptimal oral health, that is gingivitis, dental caries, tooth loss, and edentulousness, which appear to be associated with an increased risk of developing cognitive impairment and dementia. And so, you know, when we talk about oral health affecting systemic health, you know, I have a lot of senior patients, and sometimes it's a message they don't want to hear. They don't want to take care of their teeth. It's not they're not in pain. It's not a real value to them. And, you know, I continue to read this research, and it's like, this is not helping your arteries. It puts you at increased risk for a heart attack or a stroke. And now we know that it puts you at increased risk for microbleeds in the brain. And it certainly puts you at risk in this paper there's a relationship between oral health and dementia. And so, again, one more topic I would not be afraid to broach with a patient and say, ISA study was just done, and, you know, suboptimal oral health has a strong correlation to cognitive impairment and dementia, because I don't think anybody wants that. So, again, I wanted to share this paper with you because I think it's significant, I think it's important, and I think it's one we can discuss with our patients. Next up, I want to look at therapeutic strategies, and of course these are some of my favorite products, as you all know, but I'm going to talk about kind of a broad range of therapeutic strategies here. This one I thought was very interesting. Again, it was a systematic review. There were 30 studies, and they examined dentists, general practicing dentists, restorative thresholds for carious lesions. And what they found was that a significant portion of us would treat lesions surgically when we could have intervened non-surgically. We're talking about, you know, the E1, E2 lesions, or we're talking about the IC-DOS occlusal lesions that are like 1, 2, and 3, where, you know, we could use certainly less invasive therapies. And this came out in JDR in May. And I think, and actually this group produced several papers on this topic. And so I think there's kind of a changing paradigm. There are lesions that can be treated non-surgically. There are lesions that we can, you know, attempt to remineralize or arrest. And so I think we really need to be open-minded to, you know, before we pick up the drill, you know, understand the patient's risks, you know, it's causing those areas, and what can we do non-surgically first to treat those before we just start drilling and filling. Next up was a 3-year trial. And this was on children. It took place in Brazil. They did 1,000 single and 1,000 multi-surface restorations. They replaced amalgam with high-viscosity glass ionomer in restoring primary teeth. And the results of this study were that essentially it increased the cost slightly, but the more Restorations included, like at a time, the number of restorations when you were using the glass ionomer seemed to help reduce or minimize that increase in cost. And certainly high viscosity glass ionomers should be considered as an alternative to amalgam in restoring primary teeth. This came out in the Journal of Dentistry in December for your consideration. I thought this was interesting. 61 children aged 8 to 10. It was a 3.5-year randomized controlled trial with a follow-up examining an interproximal sealant on the mesial of first permanent molars in children who are high caries risk and had lesion formation on the distal of the second primary molar. And what they found was that this significantly reduced lesion formation, putting an interproximal sealant, which is a challenge to place. If you've ever done that, you may have to use an orthodontic separator, elastics, for a week, 10 days to open up the space. Certainly those, if you've ever experienced those personally, or if you've ever used them, that's kind of they're uncomfortable. They're quite painful for the first few days on those patients. So then being able to isolate and get a sealant into that spot is a challenge, but it's certainly a non-surgical or minimally invasive approach to protecting that mesial surface on those first permanent molars when you've got a lesion on the distal of the second primary molar. This paper came out in July in the Caries Research Journal. And while we don't get reimbursed right now for placing sealants, I think the paradigms are changing. I think this is a treatment that we may see more of using proximal sealants. Of course, I've used the Icon system in the past. I've tried it. It's time-consuming. Anybody that's used it, but it certainly gives us an opportunity to just reduce the site there. Next up, and this is a huge topic and has been for the last couple of years. I just got an email right before I left my office tonight from a colleague in Portland asking about silver diamine fluoride. So I've included a few studies or papers here on silver diamine fluoride, and this was actually a paper that was published in JADA in February of last year. It was a systematic review. They started with 5,980 studies on silver diamine fluoride. Let me repeat that number, 5,980 papers on silver diamine fluoride. They narrowed it down to 11 papers that were included in the review, and there was a high level of evidence that the silver diamine fluoride was 89% more effective in controlling caries progression in primary teeth. And so, certainly, this is a real significant new tool for us in the profession, both for all patients. The challenge is it turns, the good news is it works. It appears to arrest dental caries or better than anything else that we have to do that. The bad news is it turns those spots black, and it turns those spots black. But as long as the patients are willing to accept that, this is a significant tool that you should all be using, certainly on primary teeth for kids that are, that are young, patients that have dementia, senior patients. So you're just trying to, keep them out of the danger zone until they, for the rest of their life, let's say. So silver diamine fluoride is 89% more effective. This was a paper that, again, a systematic review and meta-analysis. And again, this, paper indicates, looking at all these papers, the use of silver diamine fluoride is indicated. Interestingly enough, Jeremy Horst and his group published a paper, I didn't include it here, but determined the immediate increase in surface hardness and arrestment probably of these lesions is due to you get precipitation of the silver ion into these little micro silver wires in the dentin. And I showed you the SEMs here of that. And silver, we know, is a strongly antimicrobial ion. And so it's probably not only increasing surface hardness, but is playing a role in arresting these lesions and having that antimicrobial activity in the dentin itself. And it tends then also to reduce the spread or progression of lesions or new lesion development in the rest of the mouth. So there is an overall antimicrobial effect of using it. But again, it turns these areas black, but it's 89% more effective. This next study took place in the state of Oregon at OHSU. They looked at a double-blind randomized controlled trial of 66 Oregon preschool children who had one or more lesions. They applied silver-diamine fluoride or a placebo, and they looked at 14 to 21-day follow-up looking for lesion arrestment. And the conclusion was topical 38% silver-diamine fluoride is effective and safe in arresting cavities in preschool children. So it certainly gives you another opportunity to discuss with a parent. Maybe rather than going to the operating room and let's try this, and maybe this is another, at least an alternative, less invasive approach to treating these lesions. This is a patient of mine, and one more thing that you can, this is a patient who's going to have full mouth, restoration, but we're going to be doing it one or two teeth at a time over a period of time, and it gives us the opportunity to arrest these lesions, kind of get your fingers in the dike, and then back up and treat these things kind of one or two at a time, rather than having to treat the entire mouth at one time and worrying about whether or not you're going to get the other risk factors under control. So, but again, this patient is totally, understanding what this was going to look like, totally accepted this treatment, was totally okay with it. So, again, it's got to be it's got to be a patient that, is up for that. But in this study, they looked at silver-diamine fluoride and calcium and phosphate and the growth of in saliva and the nucleation and growth of the apatite crystals themselves. This was an in vitro study. After incubation of the incipient lesions, artificial lesions at body temperature, 37 degrees for 24 hours, they examined the crystals, the shape and organization of the nanoapatite crystals in bright field transmission electron microscopy and electron diffraction. There was a positive correlation between the increased percentage of crystal size and the concentration of silver-diamine fluoride. So that's a pretty exciting result. This came out in JDR in September of 2017. Again, so silver-diamine fluoride affects the crystal growth as well, or improves it. We now know the best code from our CDT for this application is the D1354 code, which is the interim caries arresting medicament application. So the code D1354, write that one down. If you're using this material, be sure you're, charging and coding for it. The next article is on Fluoride Rinse, and this comes from the Cochrane database. This was a systematic review of 37 papers, and the conclusion was limited evidence suggests fluoride mouth rinse may reduce dental caries in children and adolescents. This is published in JADA in April, and there's an unclear high risk or potential or an unknown risk of bias because of the limited number of studies and the number of studies done by the same investigators. But again, certainly fluoride rinse appears to have a positive effect on, treating dental caries in kids. Next up, this was a study that looked at remineralization, and they compared one application of acidulated phosphate fluoride and then twice-a-day use of 1,100 part per million just fluoride toothpaste, dentifrice, compared to just twice-a-day 5,000 part per million fluoride dentifrice in terms of enamel inhibition of demineralization and enhancement of remineralization, and the results found that basically the one application of APF, but this was a 14-day study. It was only 14 days, and they had 18 patients that wore a palatal appliance. So they had a negative control, the 5,000 part million twice a day, and then the group that had the one application of APF plus 1,100 part million twice a day, 14 days. Then they looked at the surface remineralization, cross-sectional hardness, fluoride concentration, and biofilm formation. The enamel results were the same between the two test groups. In the dentin, the acidulated phosphate fluoride was better at surface repair on the dentin, but the 5,000 part per million was better at stopping surface demineralization. So it was a short-term study. we used APF for years. Now I've literally, we still use it for fluoride treatments, in the practice, but I put a lot of patients on 5,000 part per million, kind of as a twice a day as a therapeutic strategy, and will continue to do so. The next study was a cross-sectional study of 42 patients, and they looked at, I thought this was interesting, and I included it for you because I think we give patients fluoride, and then we tend to think of like, well, it's just, fluoride gets everywhere in the mouth, right? And so they looked in this study, they're looking at fluoride concentration 1 hour after 1,100 part per million dentifrice. They checked whole saliva. They looked at 4 molar and 2 anterior sites. They looked at the concentration of fluoride in both the biofilm fluid and the biofilm solids. What they found was that the biofilm fluids always had anywhere in the mouth, always had a higher concentration than in the saliva. So the fluoride tended to stick more, let's say, in the biofilm on the teeth than it did, in the saliva. The biofilm fluids were highest in the maxillary anterior region, and the biofilm solid level concentration of fluoride was highest in the mandibular anteriors, which typically is where we have most of the biofilm, a higher concentration of biofilm solids itself. That's the linguals of the mandibular anteriors, where people do the poorest job of brushing because it's some of the hardest for them to access. So the conclusion of this, which I think is important, is that fluoride distribution in the mouth is not even. So we give the patient fluoride, and I tend to think that it's doing it's doing all our work everywhere kind of equally, and the reality is it's not. And the second part of that conclusion that we need to really think about, this really affects our study site sampling. So depending upon where you sample in the mouth on any given study looking at fluoride concentration, the study site, the sampling site itself may affect your outcome in the study. So I thought that was important, and I wanted you all to kind of be aware of that. And this is the, this is the results from that study. 42 adults, 1 hour post-op, 1,100 part per million, looking at saliva, biofilm solids, and fluids. And the sampling site, it's different. The fluoride concentration as a result of that exposure is not uniform throughout the mouth. And so I think that's important for us to understand as well. You may want to selectively apply fluoride to certain lesions or areas of the mouth. Certainly I have patients, I will recommend they take a dab of the 5,000 part per million. The last thing they do before they go to bed, just put it on that site, on that root surface or in that area. Last study I want to include tonight, and we have gotten through all of these. This is the last study, and I thought this was pretty interesting as well. Same group, and they reported, this was a randomized double-blind crossover study to measure the fluoride in saliva and also in 7-day-old biofilm, fluid and biofilm solids after rinsing 3 times a day for 3 weeks with either 0, 1,500 part per million, or 5,000 part per million fluoride. And then they allowed for a 3-week wash-in and a 3-week wash-out period, and included a 1 week of biofilm accumulation afterwards. And then they looked at the saliva and the biofilm samples. These were collected from 12 participants immediately before, at 10, 30, and 60 minutes after a single rinse as well. And the conclusion here that was interesting was 5,000 part per million fluoride raises the fluoride concentration in the mouth, but only twice as high, not 3.5 times as high, only twice as high as 1,500 part per million. So, and we also, one other thing that studies have demonstrated as well is if they use the 5,000 part per million and gel and brush with a dentifrice and then immediately rinse their mouth out with water, they end up with the same fluoride concentration as if they had only used 1,100 part per million. So it's important for them to leave that on their teeth. Particularly, again, so if you've got a high-risk caries patient, you want to use 5,000 part per million, I tell them spit, don't rinse, leave it on your teeth, certainly at night, leave it on your teeth last thing before you go to bed. So if we look at the data from this study then, the 5,000 part per million does, in every test site, increase the level of fluoride significantly over the 1,500 part per million, but it only raised it 2 times higher, not 3.5. So again, I think, just information for us all to be aware of. It's certainly effective, but maybe doesn't raise it quite as high as we anticipated. And at the end of the day, it still all comes down to balance in your health, healthy diet, healthy home care, all of that plays a major role in us being able to have a healthy balance in life. So it's all about balance. And I want to thank you all for sitting through. That was a lot of scientific data to cover in 1 hour, but I hope that you picked up a few things that you found that were interesting. Certainly the number of topics that I think you now are armed with that you can go talk to your patients about. Nothing that was new and earth-shaking, but a lot of things that just continue to fill in the gaps in our knowledge and continue to expand, I think, our perspective on treating this disease and why it's so challenging to treat. So I want to thank you all for spending this last hour with me. And I think, Kendall, we have time for a couple of questions.
I think we do. And nicely done getting through all of that information. I think we delivered on our promise to do a science update. I'm going to be quite sure that happens. So thank you. A lot of great information.
I narrowed it down from 200 studies to like 45. Now I need to narrow it down to about 6 for the Kois Center. So I'll keep working on that.
You keep working on that. While you're doing that, we will answer some questions for sure. We've had quite a few coming in. So we talked a lot about, or you talked a lot about saliva and how important it is at the beginning as one of these risk factors. Are there tests that you recommend doing to assess a patient's saliva as a risk factor?
You know, there's a number of those that you can use. The one that I used for the longest period of time was just having them chew on some paraffin wax and spit in a small, calibrated cup, disposable cup. If they should be able to produce stimulated saliva, they should be able to produce 1 milliliter of saliva per minute. And if they're more than a mil per minute, that's a low risk factor for them. If they produce less than 0.7 of a mil per minute, the research is pretty clear that that's a high risk factor for them, so that they would qualify as hyposalivation. I like that term. That's a Featherstone term. I like it better than xerostomia, because xerostomia indicates you have no saliva, and I think this really fits a better description, that you just don't have enough. Another thing that you can do is just pull the upper lip back or the lower lip and just dry it quickly, and then look for saliva to start to bubble, little bubbles of saliva on, from those minor accessory salivary glands in the mucosa, both on the upper and lower inner lip. I've seen a lot of, and you can even put a 2x2 and look for it to saturate into that 2x2. I don't know that there's any. You should have bubble. You should see bubbles there within 30 seconds, and if you don't, little beads of saliva. If you don't, you don't have enough saliva. So that's another test that you can run. In terms of quantitative tests, looking at that's probably those are probably the easiest ones. Looking at qualitative tests, there aren't really any great commercial tests in my mind on the market yet. Looking at what's in the saliva. I think there will be a day. Certainly, God, we're looking at this epigenetics. I mean, we're looking for salivary biomarkers for all kinds of diseases. Those are being studied at UCLA. So you've got a number of researchers looking at genetics and risk factors for prostate cancer, breast cancer, et cetera, in the saliva. So I think that we'll finally come up with some biomarkers, maybe in the saliva, and we'll probably have a test for that. But we could be 10 years off from seeing something like that. The one thing that I do with all patients is and it's on a risk assessment form. Do you ever feel like during the day or night that you have a dry mouth? Do you ever wake up in the middle of the night and your mouth is so dry that you either keep a glass of water by the bed or you get up and go to the bathroom and get a glass of water? Certainly, if that happens, you have hyposalivation. So that's a risk factor in my mind, and that's just a simple question. And you'd be surprised if you ask that question consistently. I think you'll be surprised. In our survey, 63% of patients said that they recognize or self-report that they feel like they have a dry mouth at some time in the day or night. So easiest to have them spit in a cup, and easier than that, ask them if they have a dry mouth.
Good answers. The next question, so on the topic of genetics, with genetics playing a role, how do you incorporate genetics into your assessment of patients' risk at this very moment?
That's a really good question, and that's a huge challenge. The only pattern for that disease that's distinct that we can identify is with the lysyl-2 gene, and that affects, lysyl-2 is, again, a protective proteolytic enzyme excreted by the submandibular glands. And so if you see a patient who has only lesions in their mandibular incisors, you probably are looking at a patient who has a lysyl-2 deficiency, and that's a genetic issue. Beyond that, we don't really have a whole lot of other tests that you can assess for any genetic predisposition. We know 45 genes that play a role, but I don't really have any way I can test for those genes yet to counsel a patient on that. The best thing that you can do is if you go through all of their saliva, diet, and bacteria, and you come up blank, and they have a lot of Caries lesions, you're probably looking at a genetic issue. And then the best thing you can do to counsel for that patient is just try and help them limit their acid exposures, try and maintain homeostasis in the mouth, help them to understand how important those acidic episodes are during the day. And if you are genetically predisposed to this disease, you may need to, this is a patient you want to put on more fluoride. Is a patient that you want to make sure that they're doing adequate home care and that they're aware of the dietary risk as well. So it's coming. We're just now starting to understand which disease or which genes really influence this disease, and I think it'll be a while. But again, like the salivary biomarkers and enzymes, I think you're probably going to find that we'll be doing testing for genetic predisposition to Caries. They're starting to do that for a couple of diseases. So again, we're years away from that, but it's coming. In the meantime, there's only one distinct pattern. Beyond that, if you come up absolutely blank on all the rest of the risk factors, you're probably dealing with something that's genetic.
Excellent. Well, I think we packed in a lot of really good information, so we will go ahead and wrap up here. Thank you again, Dr. Kutsch. Your insight into these topics is always enlightening, and I know our attendees appreciate it so much. Any questions for our attendees that we didn't respond to, we'll answer in the next few days over email. I'd also like to mention that if there is a part of the webinar you want to hear again or you missed, we'll be sending out a recording soon, so be on the lookout for that. And please contact us if you'd like to schedule a one-on-one webinar to go over the Carifree program or talk more in depth about anything that was covered here. Dr. Kutsch is definitely our science guru. But thank you so much for joining us, and we hope that you all have a wonderful night.
Yes, thank you everybody for spending the last hour with me, and I hope that you found it helpful and enlightening, and good luck in treating your patients with this disease. Good night.